All right. Hello, everyone. Thank you so much for joining us tonight. And thank you for the flexibility of being able to hop on with us and while we switch this to all virtual. My name is Nikki Smith. My pronouns are she, her, hers. I am a programming partner with Inclusive Communities. And before we start, I do want to take a moment and just acknowledge the traditional homelands of the Native and Indigenous people who have lived and continue to live on the land that we gather upon. These lands were originally inhabited by the Umahan, Ponca, Pawnee, Odo Missouri, Santee, Dakota Sioux, Kansas, Iowa, the Cheyenne, and the Winnebago people. We take this time to acknowledge the past, present, and future of Indigenous people and to recognize the ever-present systemic inequities stemming directly from past wrongdoings and strive to commit ourselves indefinitely to respecting and reconciling this long history of injustice for all people. A little bit about Omaha Table Talks. It was originally created in 2003 by the Social Justice Advisory Committee of Catholic Charities of Omaha. Inclusive Communities acquired OTTs and shifted that to kind of a larger public discussion over comfort food. And then of course, during COVID, it was all virtual, as it will be tonight, but hopefully if you have a nice snack or beverage with you, it can kind of feel like we are eating together. Last spring, we partnered with the Nebraska Asian American Leadership Alliance to start the Asian American Pacific Islander Table Talk series to have these conversations focused around AAPI topics. I would like to thank and acknowledge our sponsors, the Lozier Foundation, Cox Communications, and American Family Insurance. And as you all probably saw, we do record the panel conversation and the share outs at the end, but we will not be recording the breakout sessions that we'll have in a little bit. I do want to just take a minute to acknowledge our Inclusive Communities volunteer facilitators, as well as our ASL interpreter. We do have auto closed captioning if you do need that. And then we have also partnered with World Speaks to provide simultaneous Spanish language interpretation. So if you do need that, please just send Colin a private message and he can set that up for you. A few tips for anyone who will be speaking tonight. Just please make sure that you speak clearly, take pauses, keep a consistent pace. By following these guidelines, that is going to allow the interpreters the chance to translate accurately the information to the audience. So we will here for the panel for a little while, and then we'll break out into those breakout rooms. I'll let you all know when that's going to happen. And then at the end, we'll come back together and do those share outs from the breakout room. So with that, I will pass it over to Yoon, who is our wonderful moderator for the evening, and let you hear from our panel.
Thanks, Nikki. So pleased that you could all join us this evening. I'm Yoon Saksena. I work at UNMC College of Dentistry, so I'm a dentist. And I'm the Associate Dean for Education, Diversity, Equity, Inclusion. And with me, we have three wonderful panelists. I'll just say their names and then they can introduce themselves. Dr. An-Hoa Giang, Dr. Howard Liu, and Falah Rashoka. So An-Hoa, how about you introduce yourself for us?
Thank you, Yoon. Hi, everyone. Thank you all for being here and listening in. And I feel very honored to be invited to this talk. My name is An-Hoa Giang. I am currently a family doctor practicing family medicine and obstetrics over at One World Community Health Center here in Omaha. I just moved here to Omaha September of last year, specifically to work at One World. And my background during my residency was doing a lot of work with Vietnamese American and Vietnamese patients, as well as global health work in Vietnam during training.
Wonderful to have you. So One World is a federally qualified healthcare center, in case people don't know, and it's in Omaha. Dr. Liu, Howard?
Thanks so much, Yun. It's a pleasure to be here. My name is Howard Liu. I'm a child psychiatrist and adult psychiatrist. I'm also chair of psychiatry at UNMC, which is the academic health center here, University of Nebraska Medical Center. And I'm a second generation Chinese American. And actually, my parents are here in town as well. So everyone's unified here in Omaha. And on a daily basis, I do a lot of administrative work, a lot of community engagement as well. And really excited to be here just to talk about Asian American mental health. I'm going to give a shout out to my daughter, who's also tuning in today, who started an Asian American leadership club at her high school for the next generation of hopefully healthcare or other community providers. So thrilled to be here. Thank you.
Great. And then Falah, Rashoka?
Thank you, Jan. It's my pleasure to be here with you all. My name is Falah Rashoka. I'm a doctoral student here at the Department of Nutrition and Health Science at the University of Nebraska, Lincoln. Also, I am MPH, Master in Public Health candidate at the University of Nebraska Public Health, UNMC. Also, I am a registered nurse candidate with the Department of Human and Health Services here in Nebraska. I'm first generation refugee. I moved to the United States after I worked with the US Army for several years. Then I moved with my family to the Nebraska, and we are living here since then. We become, all my family with myself, we become United States citizen last year. I done a lot of study about marginalized communities here in Nebraska. Some of our research work had been published in several journals, others under review. We intensively did many study about community-based intervention, healthcare barriers among marginalized communities, and some more stuff. I'm going to talk about some of them today in our panel.
Sounds great. I mean, we've got a diverse panel representing different cultures and also different aspects of healthcare. So for each of you, for the AAPI community, what are some of the barriers to healthcare that you're seeing? Anyone, just jump in.
Well, I'll just start off from the mental health community. I think there's a couple of things. One thing that we talk about is culturally and linguistically appropriate services, just meaning that both on the cultural end of things, that sometimes you understand where your patient is coming from a family perspective, just a community perspective, and linguistically, that the language is also something that they are familiar with and comfortable with as well. And I would say that one of the barriers is just making sure that our workforce in mental health and healthcare in general reflects the populations that we serve. And I think that that's something that we always strive for, but it takes really working upstream on some barriers. And then sometimes the Asian American community is seen as one monolith, like one thing, right? When in fact, it's so many different communities. And we need to look at who is underserved even within these communities, which is, I think, part of the dialogue today.
And then Falah, you've done some research, you alluded to that. So what are some of the barriers that you discovered or that you wrote about?
Yes, thank you. So a lot of people think being Asian, this means they doesn't have any problem. There's a lot of media attention on Asian people that they have high income with high educational level. So that doesn't mean all of them, they are kind of have high educational level or high income. Some of them still, or majority of them still have problem when it comes to the access to the healthcare and how to navigate the healthcare system in the United States. And you all know how complicated the healthcare system here in the US. So that's the big problem. During my research work in past 4 years or 5 years, and even through my work in Lincoln Lancaster County Health Department, we found there's many barriers that prevent them from accessing to the healthcare. I would like to mention a specific thing happened with me. One day during our research work, one of the participants in our study mentioned that one of the patients has visited emergency department for 79 times during 5 months. Imagine if that person has ability to access to the healthcare, I can say primary healthcare, urgent care, or whatever, at the first level, he's not going to visit emergency department for 79 times in 5 months. Imagine, and you staying in emergency department for 5 hours, 6 hours. So this is huge. What we found during our investigation, during our ongoing research, we divided it into the different teams. First one, we said, or we found that informational barriers is one of the big problems that they are facing. And within the sub-teams in informational barriers, we included language barriers and knowledge barrier. Language is a huge issue. Still, according to the census data and governmental data, 1 out of 3 of Asian people, they have problem with English language, or they are not fluent in English language, and not being able to speak language will when it's come to the healthcare, it is so problematic, and different terms, different stuff. It's kind of hard to get it. Also, the knowledge barriers. Some of them they don't know where to go or what service they can get. Is that urgent service, emergency service, or it needs kind of family appointment? And even with that, it's a big problem when it's come to the long of the appointment time and the stuff. Also, we found resource barrier was also one of the big issues. Living, in isolated neighborhood, not having access to the good health services also was one of the big problems or barriers our Asian community is facing here in Nebraska. Last thing I would like to talk about, the social barriers was one of the big problem. Cultural norms. Some people they were practicing specific kind of culture when it comes to the healthcare services in their country of origin, or I can say in Asian country. But when it comes to the United States, the system is totally different. The healthcare system is individual; it's dependent on the individual. While in the other countries, probably it was family based. They're gonna share the problem with the family. Then they can all discuss the health issue. Here, it's individual, and the problem should be discussed only with the patient. So this is one of the kind of main problem we found during our research work.
That's a lot of main problems. Yeah. And then Howard had alluded to the linguistic appropriateness of things. And what about your experience, and what have you seen about these health barriers for the AAPI?
Yeah, I absolutely agree with what Howard and Falah kind of both agree on, which is linguistic barriers and cultural barriers. And I have so many examples, but linguistically, specifically in the Vietnamese community that I see, just within, and I think that this conception of, it's just like Asian culture in general is like one culture is like an erroneous way for us to approach patients, because even within the Vietnamese country, we see many different cultures within one single country. Linguistically, even within Vietnam, depending on what translator you get for a Vietnamese patient, and because I speak Vietnamese, I could hear the difference whenever I get a Vietnamese interpreter. If the patient is from a certain region of Vietnam and you get an interpreter that's not from that region, oftentimes the patient can't understand even most of what the interpreter is saying. And I think culturally, at the same time, there's the play that that patient will be too embarrassed or not want to bother the physician by telling them, actually, I don't understand what that interpreter is saying. And so that leads to a lot of a visit that the patient just keeps on nodding and saying yes, yes, when actually they don't understand at all what you're saying. And it becomes a huge problem in the hospital, especially when you're trying to explain to a patient discharge instructions and trying to prevent another hospital admission. I think culturally, I've seen a lot of examples, especially in obstetrics, specific to the Vietnamese community that I served back in Massachusetts, was the culture of just not speaking up when they're laboring, because in Vietnam, I found out just this past trip that I went to back in Vietnam that a lot of women who are laboring, if you did not pay for the labor and delivery, and it was free of charge, they would get yelled at if they asked for anything, like if they asked for water, if they yelled at because they were in pain. And they carry that culture with them, and they carry those memories with them over here. And when they're on the labor and delivery floor, they just don't say anything. And as a doctor, I think we see patients like that, and our first instinct is like, oh, this patient is so adorable. They're so nice. They're so peaceful, amiable. But in reality, they're just afraid of telling you that they're in pain because they have memories of not being treated very well in certain circumstances.
Yeah, I think we've all seen the nodding in agreement, even though we're not sure what is being meant, because they want to please us and do the right thing and be respectful. And that's one way of showing respect. And when you think about, being in pain, I'm a dentist, and then, sometimes people don't want to ask for anything from you. They feel that you should do everything, but at the same time, they think that, oh, maybe you're going to charge them more. Like even for anesthetic, for instance, some people think that we're going to charge them more, and they don't know what's included or what to expect. And some people are, we talk about some of the cultures and their backgrounds. Some people have never been to a dentist. They don't know what they're in for. They don't know what's going on. And it's very scary. So it kind of shuts them down too. Yeah, a number of you have direct immigrant experience, or your parents have. So I think it compounds it too, because you're talking about the culture and like An-Hoa about Vietnamese in Vietnam, how they do things so differently, how healthcare system is different. And Falah, you kind of alluded that to too. And then, Howard, you've got grandparents that have a completely different experience. And we have a lot of immigrants, especially in Lincoln, when you have refugee populations. I'm not so as familiar with Omaha, but can you tell us about some of that immigrant experience that you've had, or some of those firsthand things? And do you want to do it first? Because I know that we talked about the language and how you helped your family.
Yes, thank you. Yeah, so it is a complicated problem. Actually, still my mom, she's here with me in Nebraska, and still she's facing problem. She's not used to the system, to how to navigate the system here. Back there in her country of origin, there was no need to make appointment. She can just stop by a clinic and be seen by a doctor, or even with the kind of diagnostic test, lab test, she can do it. Even would not need to the having a family doctor signing it. So it was kind of easier. She's facing problem with that, which is a big issue. And when it's come to the interpretation, it is big issue. And here in our lab with Dr. Megan Kelly we create a health lab. We try to find out what like how the experience look like when it's come to the interpretation. And we found that dialogue also has a huge impact on the medical services they got, because each person, when it's come to the Asian, we have a lot of language, and in the same time we have a lot of dialogues, and each dialogue is using specific words when it's come to the medicine. And each word could be different meaning when you translate it to the other dialogue. So dialogue was big issue. In the US, when we are talking about dialogue, people are thinking that the South Korean dialogue is kind of different than what we have in Midwest dialogue, but there is no much kind of huge differences in the words we are using. When it comes to the Asian communities, the dialogue, the words they are using, it's different. So that's the big issue. That reason, this experience led many people to not seek the care. Many of them, they delayed getting the care, which led to the developing chronic disease, coming, with the heart disease, diabetes, and other disease. The main reason, because they are feeling, if they got to the healthcare provider, they're gonna face a lot of problem rather than what they have. So they just try to stay home, not getting to the doctor and keeping that. So that's one of the according to our study, that was one of the big problems that led to the more chronic disease, more health issue among these communities, especially marginalized community in Nebraska.
You raise an important point, because these health barriers, some people say, well, so what? But it impacts their health, and it can also death, right? An-Hoa, can you tell us a little bit about your experience translating? Because I know we had talked about that briefly on the side.
Yeah, so I didn't say it, but I'm first generation Vietnamese American. So my parents came over a few years before I was born, and they were Vietnamese refugees. So I have first-hand experience just growing up in an immigrant family and then witnessing my parents trying to basically assimilate or trying to learn English and never really quite getting there. I come from a very large family, so I have 3 brothers and 3 sisters, and all of us, I just thought was the norm because I saw my older siblings going through the same thing, where by the time we were in 3rd or 4th grade, it was an expectation that we would like fill out our own like EBT forms, so electronic benefits, or TANF forms, like temporary assistance for needy families. That was also an expectation that we would take turns and bring our parents to any appointments that they needed, like with social work or to doctor's appointments specifically. So I remember distinctly the very first time I was asked to accompany my mom to her women's health appointment. I was in 3rd grade, so I was probably like 9 years old. And even though I was colloquially fluent, I was not medically fluent at all growing up, because my Vietnamese was from just speaking to my parents, which was pretty formal. And I never really at that time spoke really even about emotions with my parents. So my vocabulary was very limited. And during that women's health visit, the first few questions in, I knew I was sweating because I knew I didn't know those words. They asked my mom about her menstruation, they asked about her bleeding, and I just didn't know how to explain any of those words to my mom. And they couldn't get an interpreter for her because I lived in Pennsylvania at that time and there was no access. So I just had to make do and try to use other words to try to explain what I thought was going on. But I still see that now when, you know, if we see parents and we see family members that we can't get an interpreter for, as a community health center, and I think our community health center does a really, really good job at One World of trying to get an interpreter, but sometimes our hands are tied if it's a language that's not common. We have to do the best that we can, or else we'd have to cancel the patient's visit. So it puts us in a tough position. And I would imagine being at not One World, being at a community health center or being at a clinic that's very rural, your hands would be tied even more with a rare language.
It seems so unfair too, and putting the burden on the kids or the families to find their own ways to navigate the system. How about you? Because you're in psychiatry, and I think those terms will be even just as complicated too for people to translate and to figure out what's going on. You know, thinking about how appropriate and, you know, how do you translate? What do you do in those situations? And
well, I think it's tricky, and you know, there's a huge shortage of mental health providers pre-pandemic, right? And it's only gotten worse during the pandemic. And there's also some data that Asian Americans access mental health less frequently than the average US citizen. So probably about maybe 1/2 to even 1/3 of the access rates. So that speaks to the stigma piece that I think prevents people from going to seek care, and sometimes shame and just a sense that it might reflect on the family or other pieces like that. So in my own family, my father is a physician and he's a pulmonary sleep specialist, ICU, and retired now. But interesting, going into the med school, he never discouraged me from going into mental health, and I'm glad about that. But I find that I think you have to be active in the community, and something that I've gotten more involved in over the last few years here in Omaha. I've been here about a dozen years, and I've noticed even going to a small Chinese church that, you know, if you are visible in the community, people come talk to you about things in a way that they won't if you are, you know, just a talking head on a Zoom call, right? And so I think you have to be visible in the community, and then just speak up about it, and things that might have been taboo. You just, you know, make sure that people are aware of that there is help available, and there are these people that, you know, that might be delivering it, right? I unfortunately lack the language capacity. My Chinese is terrible, very poor. And so I don't have linguistic fluency. So I have some elements of cultural fluency, but as An-Hoa was saying too, I think there's just all these variabilities within communities as well. But really trying to address some of that stigma just by being out and about and then being active in the community, I think is really important, especially if it's a stigmatized area like mental health.
Yeah, and then knowing how approachable you really are, and then where to get the services, because we talked about that being a barrier, just knowing where to find things or who to go to. Yeah, with the language in dentistry, that's even harder with some of the terminology. And then, we've found that when people say, "Oh, I need a Chinese interpreter," then I ask them, "Well, what kind of Chinese?" Right? Because the different dialects, and they say, "Oh, we're good. We've got a Chinese one. They speak Mandarin." It's like, it doesn't really work. My patient speaks Cantonese, right, or some other dialect. And then, with my students, again, I say to them, well, what other tools are available if you can't find that interpreter, because the kid's not going to know. And your high school Chinese, you don't know how to talk the lingo, the language, and how to explain these things to them. So draw things. It's like, well, yeah, I mean, it's so much more difficult when people say, well, but it takes so long, I don't want to see those patients. It's like, oh no, you need to. It's so sad. Yeah, and then I want to sort of talk a little bit about discuss a little bit about cultural humility. We think about being aware, where we're acutely of the food or some of the differences, but what does it mean? What role does cultural humility play in breaking down these health barriers for the AAPI community? Howard, do you want us to go first this time?
Well, I think it speaks to that aspect that none of us are really an expert, right? And sometimes we trip ourselves up if we make an assumption, especially if we're rushed for time about this person in front of me or this family coming for care, and we take shortcuts, right? And I think that's exactly the wrong thing to do. The challenge is that the healthcare system is sometimes optimized to really try to get people through quickly as possible, be most efficient. But I think if you even take some time early on to ask some of the cultural questions, I think that's really valuable. I have a medical student teaching clinic. I noticed there's at least one med student on today. And I think that when you're having that kind of opening interaction, early on, asking about culture is important. Is there something I should know about your family? Is there something I should know about your culture? And then just actually listening to what people are saying, that's really critical. And understanding that, there's some barriers, right? Using interpreters, sometimes things are lost, right? And there's some nuances, as Falah's talked about as well, about information gaps and just understanding that you have to put these things together. Also, I'll just say about one more thing. I saw something come out on Twitter recently just about how trauma underlies so many things, both physical health and mental health. And a lot of those things are not going to be disclosed at their first visit, first time you see somebody. And if they're not comfortable with you, they may never be disclosed. So understanding that sometimes it's a process, really getting to know each other, building that trust, and the time is important, and just having that humility.
Yeah, An-Hoa, about you, about cultural humility. Any comments about that?
Yeah, I think fortunately I work in an FQHC now that continues to remind me to be very humble in terms of cultural competence, and there are just reminders like very frequently in my day-to-day work. But like Howard said, I think that sometimes as physicians, we move quickly through things, and especially with the Asian American community, the less they say or the less they complain or the more they nod yes, the more we want to make ourselves believe, okay, everything's fine, everything's good. They understand me. And I don't know if there's a secret formula for how you can get them to be more comfortable with you, to share with you what your plan is, that they're not going to follow through with your plan because they don't want to disappoint you, like the patient doesn't want to disappoint you. But I think it's in those moments when you're right at the peak of being frustrated because they're not following through with your plan, that there is that one chance or that one opportunity that maybe something about your mannerisms might make them feel comfortable enough to tell you why they're not doing what you're asking them to. And I mean, one of the very first times that happened to me, which I think that work in these types of multicultural, multi-ethnic communities, so I can start making myself believe, oh, I'm very culturally competent, that I stopped looking for these inconsistencies. But then when it's in my face, like recently, I had a patient that shared with me that culturally, and this happened, Vietnamese patient as well in UMass, very similar story, but a different culture, Guatemalan patient that I did a C-section for. And I kept on telling her to get up out of bed to walk so that she wouldn't develop a blood clot. But she wouldn't get out of bed. And I just kept on going into the room and telling her, you need to get out of bed. You're going to develop a blood clot. And then eventually her husband pulled me aside and said, in Guatemalan culture, after a C-section, you're supposed to lay dormant for a month. And so it just hit me because it reminded me when I had done very similar story when I was a resident. There was a Vietnamese patient, same thing that happened. And so you would think that I would have thought to think, okay, maybe this is a cultural difference, not just because she's lazy, not just because she just doesn't want to get out of bed. But it's moments like that that just remind me how very important it is for us to, something about us as clinicians allows patients to share with you why there's that discrepancy between what you're telling them to do. It's not just because they're being stubborn.
Yeah, you raise a good point about just making the time for the remembering that they're people that we're serving. And just like Howard said, don't make the assumptions, right? Give them the opportunity. And it's so hard because we're, as healthcare providers, we're rushing around because there's so many people waiting and there's so many reasons we just got to keep moving. I have to keep reminding my students and every now and then myself, it's like, okay, that's a person there. It's not just a mouth. It's not this, it's not about the procedure. It's about they're taking care of that person. Falah, what other comments do you have about cultural humility and the role it plays in healthcare?
Thank you. This is a really great question. So in our lab with Dr. Megan Kelly, we create health. We faced that issue, and many of the participants in our study said, "Well, we are facing problem with the healthcare provider. They are providing us with a different interpretation service. They are taking kind of stereotyping. They thinking that because of our ship or being an immigrant or refugee, they are thinking different way. So anyhow, we decided to develop culturally educated materials, and we sent it out to the healthcare provider in some health institute here in Nebraska. And in that video, we talked about the Yazidi refugee immigrants here in Nebraska. We have 5,000 Yazidi here in Nebraska. So we in that video, we included much information about the culture, about the language, about how trauma they experience and all those issues. And we did the pre-test and post-test with the healthcare providers. What was amazing that pre-test, many of them, they don't know like what is the Yazidi, if there is anybody with kind of a Yazidi name living in Lincoln, Nebraska, or Nebraska as well. And also many of them, they have no idea if the patients from that community need interpretation service or what dialogue they are speaking. And post-intervention, we took post-intervention as well. The level of knowledge among healthcare provider been increased to that kind of 100%, which was amazing. That was just only pilot test among specific group, and we talked about the Yazidi. So I believe we need more educational materials about the Asian communities, not at the kind of community level, but we need to educate the healthcare provider. That's the issue. Like many people are developing stuff through the healthcare center or through the cultural organization or NGO targeting refugee or Asian communities on how to educate the kind of those communities. But in our lab, we said, okay, let's look at the problem from different view. Let's try to educate the healthcare provider about those communities, about their culture, about the trauma they face, language, dialogue, all this stuff. And it was successful, but it was kind of small pilot test. I believe we need more such pilot tests among Asian community here in Nebraska.
Yeah, more, and then we can learn more, so much more too. And then like part of the humility thing is realizing I'm Chinese, but that doesn't mean I know about Chinese people because it's so diverse, right? and then try to be open-minded and learning from the different perspectives. We're going to want to make sure you have time for discussions in the groups. So I'm going to pass it back to Nikki, and then we can talk more later about how we can break down some of these barriers.
My group had a great conversation, and Andrew was going to be our speaker. We had kind of a doctors group from One World on ours and some other great experts. So it was really great. Andrew, go ahead.
Yeah, for sure. Thank you, Sherry.
Thank you.
We spoke quite a bit, just around the challenges of navigating the American healthcare system. From the medical folks in the space, there's conversation a lot around recognizing that they shouldn't be focusing on biases or judgment for someone's lack of experience or knowledge with healthcare, and instead take the time to assist with educating and really trying to be a really solid resource for folks and ensuring that there's more comfortability for people in that space. There was also a lot of conversation, of course, around translation and interpretation. When you have children or family members that are involved, and some of the more challenging aspects of the language line versus having family members translate, and the fear of maybe medical information not being properly discussed. And yeah, it was a really fruitful conversation, I would say, overall, and really encouraged us to think a little bit more broadly about some of the other intersecting identities. So it's one thing to maybe identify as Asian or Asian American, but let's add being rural on top of that. Let's add being an immigrant or refugee. Adding these different layers can create even more barriers. So making sure that we're looking at the whole picture of everything when talking about these issues.
Awesome. Thank you so much. That sounds like you had a great discussion. Someone from one of the other groups, either one, go ahead, jump in.
So I can go next. I was with Dr. Strong, Dr. Saksena. I think we were lucky to have a very diverse group. I think that was a strength of our group. We got point of view from a lot of different people. I think one thing which stands out every time we have a discussion like this is every time we talk about this, it's an eye-opening experience. Even when we have had these discussions, or we have all thought about it and talked about it in the past, hearing it is always, again, an eye-opening experience. I think the other thing we talked about was how there's a difference in healthcare here, where it's considered a very individual thing versus how healthcare is viewed in Asian American culture and Pacific Islander culture, that it's a more of a family thing. That difference speaks out every time we talk about these things. Some of the barriers we talked about was how life is viewed differently in different cultures, and how different phases of life are celebrated differently, and how we accept those differences and still have a way of accepting those differences and making sure we provide the care we need to provide to people. I think the last thing we talked about was having that cultural humility and being curious about someone's culture without being judgmental. So I think that's the bottom line we need to have. Just the reason my video is off, because that makes my internet unstable. So I don't know if it's on my end or on the other end, but so that's the last thing I'll say. And I'll pass it on to the next person.
So I believe I'm the last facilitator going. Our group trusted me with sharing some insights. We had the luck of having a group in which everyone was AAPI or of AAPI heritage. So it was really a privilege for me to be able to be there. We talked about anecdotes. Every single person in the group had something that they could bring up instantly that was a healthcare barrier. Sharon brought up that there are folks who are nervous about going, that are nervous about being labeled as something like nervous, because it could affect the marriage prospects of their children. Alex had a grandpa who had a bad toe and didn't want to be a burden. Everyone had an anecdote that illustrated the very point we're making. And I think the most robust part of our conversation was a discussion of what do we do now? The problem is apparent, the challenge is apparent, but what could we do? So some of the suggestions we had is Dr. Howard said, there's no online directory, there's no resource that tells you where to go if you speak Newer or Vietnamese or anything else, and you need a doctor that understands that experience or speaks that language. Where do you even go? There is no comprehensive online directory for that. Falah was talking about mental health stigma and how we address it sort of going forward through generations, and especially men in many Asian communities. That specific part of stigma needs to be addressed so that more men are willing to go to a mental health provider. And Sharon brought up that we need to give people the questions to ask. We need to empower them to be able to say the right things and ask the right questions so that they can be more robust in their help. So.
Awesome. Thank you so much. Since we have a few minutes here, we can open it up if anyone has questions for anyone on the panel or just the panelists as a whole. And then before we leave, I think that we'll have one more question that we'll just ask the panelists to kind of share their main takeaway. But if there's any questions that anyone in the audience kind of has for the panel, feel free to type that in the chat or just unmute yourself and ask those questions.
So I have a question for the panel. We talk about, when we talk about our patient care as like the culture or the background they come from, but how does a physician or a provider's culture affects patient care? How much role that can play or should play in the care we provide in our clinics?
Well, I'll just take that, Varun. Good to hear from you. And I think it's a lot. I mean, and it can make all the difference. Just like the early example of what you disclose. I had a student with me today, and we're talking about how do you ask the sensitive questions about substance use and sexual health and all these things. And really, it's about establishing that trust, as you know, as a child psychiatrist and someone that works with youth with a lot of trauma yourself. So I think that it can make all the difference. I know there have been studies too on women physicians and Black physicians, and they have better health outcomes when they're aligned with their patients, right? And so there really is some of that data, but I think it's also just being sensitive to the nuances, but without perhaps assuming the stereotypes, right? So I think it really does matter. And I think it helps people even come to you for the first time. I know that there's a lot of discussion earlier just about being visible in the community. And I think that, if they can't curbside you wherever you're at a restaurant or somewhere else, sometimes that appointment doesn't happen at all, right? So I think it's just a lot of those factors. I'd love to hear from others on that.
So for me, I think it does make a big difference. And it can impact in a very positive way. I see it as more of a positive factor, but I'm sure there are examples of it negatively impacting your ability to care for a patient. I really, truly do believe that, at least for the Vietnamese patients that I've taken care of, as soon as I walk in and they know that I can speak their language, I can just feel, I know that the chances of them actually following through with things, the chance of them returning for follow-up visits is a lot higher, because there's, I guess, less of a barrier, I feel like, for them to trust me. And maybe that's because a lot of like human language really isn't spoken language. Maybe they feel like my bias, my bias towards them, meaning that, I really want to take care of Vietnamese patients because a lot of times they do remind me of my parents or my family, and I would want to take care of them in ways that my family has been taken care of, or in a way that I would have wanted my family to be taken care of. So I think it goes both ways. Maybe they can feel that and they can sense that from me, that I have their best interests. That's not to say that I treat my other patients that are non-Asian like poorly. It's just there is a sense of connection automatically when I know and I recognize that they are Asian, and specifically Vietnamese even. So yeah, it can greatly positively impact the way that I care for patients and the way that patients receive my care.
Oh yeah, yes. As they mentioned, it's important. It's positive. The only things as outside of kind of practicing field, some of the participants in our study mentioned that the only problem they are facing when the healthcare provider from the same community is privacy problem, especially when it comes to the maybe abortion, sexual, this kind of stuff. When the healthcare providers from the same community, they are feeling that their privacy probably is gonna be online. Probably some people are gonna share it with the other communities members. That's gonna be the problem. That was the only negative points that we found in our study. All other stuff was good, like having the provider from the same community always has a good point.
Yeah, as in dentistry, like the patients are, a lot of them come petrified, right? It's a scary experience for anyone a lot of times, and even worse if you don't understand what's going on. And even though I don't speak Chinese, the way I look, at least people can kind of relate, and I can sense that. I can sense that in the patients too. Even if I don't speak the language, they'll just assume they do and start speaking to me in Chinese. And I'm just saying Chinese that I understand, but I can't speak it. And even just a one-way translation, again, it does help them, like knowing that that I look like them, and that I even though I don't understand, everyone's different, that I have some inkling about what they're about.
Thank you so much for your answers. I think it's similar to, I think, what my experience has been, but I just wanted to hear from everyone else's thoughts on this.
Great question.
I would just like to thank the group. It's been a wonderfully diverse panel with different health backgrounds and different personal backgrounds. So this, I think, has been a wonderful group to hear from.
I have a quick question. Like as myself, I'm a student at UNL, and I'm seeking for dental school. As we mentioning about providers, like I've taken all the prerequisite classes. I've never seen any requirement that mention about culture or anything that talks about different, like different backgrounds, or like that's gonna be maybe that would be like a requirement for a student to take in order to apply for those schools. So because like this kind of way, we'll make sure that each student who are going through dental or medicine or anything, they will have at least experience. They've read about different cultures, social, or anything that's related.
I really like that point, and it's so important to all healthcare providers. I think we find out about that from talking to the candidates about their personal experiences and hearing those stories, and how they've participated, and more than the courses, because sometimes it's hard that not every college or university, now they probably do, but back then when these structures were set up, we want equity as well. So having access to all these courses and things, and what does it mean? I think they're much more accessible now, but as going to medical school, dental school, any of those healthcare professions, there's a lot of prerequisites. It's very demanding, and we want to make it more open to people and welcoming. We don't want to put any more barriers, but I see the value in that. You make a very good point.
Any other questions?
I see a question about whether AAPI representation on teaching staff influences ability to serve AAPI communities. I don't know the answer offhand. It's a great question. I do know that when you talk about representation for any group, really, sometimes we talk about the workforce as a whole, but in academia, also looking at it by rank, associate professors, chairs, deans, CEOs, hospitals, those kind of things, you often find less diversity as you move up, right? And I think it's important that visibility. We had an MLK Day keynote speaker from Charles Drew Health Center, Kenny McMorris, the CEO, yesterday. And when people asked him what he had hope for, he said, he had hope that, his kids, right, that he's African-American, and Dr. Strong here actually facilitated that keynote, but just said that they'll be welcomed in places of power and influence in a different way than he was, coming up. And I think that those pieces to your question, Sarah, are important, right? Not just, at the front line doing the care, but also who's running the clinic, right? Who's writing the grants for these research studies that Falah's doing, who is the dean of the college, as Sharon has been a dean at Creighton as well. So you see all these pieces really matter. And I think the representation at all levels. And I know that Dr. Saksena is also an associate dean in dentistry, and I think that matters, right? As you look at who's really there at the senior tables.
And we have Dr. Lee as the chancellor of UNO. So that's pretty exciting.
Yeah, I think she's the most senior official, right, in the NU system of Asian American background.
Yeah, we talked earlier about people. What does it matter if the provider's from one culture or another? And we all want to learn. But then we also realize that people feel more comfortable with other people that look like them, right? And then therefore we need more people, more minorities in healthcare. It helps with compliance. It helps with just humanistic approach to healthcare and accessibility, because Howard already talked about, well, people may not talk to you or may not make that point when you talk about the structural barriers. And then that's just having that connection wherever it is that they see someone, it's like, oh, there's the phrase, and you can't be it unless you see it. Like you can't imagine yourself being a dentist or a doctor or a psychiatrist, because you don't need. Sometimes people don't even go to them, right? Number one, and then they don't have any role models or mentors or people to help them there. And we need those so that we can have better access. That was one of the barriers that we kind of talked about, the structural things that were preventing people from seeking care.
Yoon, were there any last questions that you didn't get through, or did you have a final question that you want to ask the panelists at all?
Just like, what is there was one take home for this group. What would it be for tonight?
I think just recognizing that each of us, by telling our stories, really, we can address the stigma. Whether you're a member of the community that's featured, in this particular table talk, or an ally, I think your story and people that know you, it can make a huge difference. I know that's true for mental health. So I really appreciate everyone being here and really being vulnerable, both on the panel and also in the breakouts. It's really important. Thank you.
Thank you. Well, I think COVID-19 pandemic was a good lesson to us as Americans to know that what we are facing is collaborative issue. We should act as a community. At the beginning of COVID-19, we were curious that there is no any case of COVID in the community, because having any case probably is gonna transfer to all the community. So here's the point. I believe it is collaborative responsibility. We should work together as a community to improve the access to the healthcare, reduce disparities that our minority groups are facing.
I think for me, there's a lot of takeaways. All of you contributed a lot to the conversation. So thank you all for sharing and being here. But I think just continuing to be humble and continuing to be curious, no matter on what aspect of whether you're in healthcare, whether you're in legislation. I think the more that we learn about ourselves and about other people, the more we're able to help others.
Great takeaways. So much there. Thank you.
Well, thank you so much, panelists, and Yoon, for giving up your time tonight, for sharing some of your experiences and your stories with us. I know I learned a lot, and I know that everyone here did as well. If there's no other questions, I think that is it for the night. Again, I will ask you to please take a minute to fill out that evaluation. It really does help us learn how, if there's anything we need to do to make these better or more accessible for folks. So those evals are really helpful for us. But thank you again, everyone. This was a really great conversation tonight.